Our next session is really exciting. Of course, we are looking at some other treatments that are beyond pharmacological and devices. And so really excited to hear the next session.
Yeah, I'm looking forward to hearing about complementary and alternative medicine for gastrointestinal disorders by our dear friend, Dr. Tony Lembo, who is at Harvard University and has a lot of experience in this space. In fact, did a lot of the foundational trials on acupuncture for irritable bowel syndrome, and then dietary interventions for GI disorders. And that'll be given by our lead dietitian at University of Michigan, Emily Haller, who's really an expert at GI dietary interventions.
Absolutely. And she's been a great friend to IFFGD. So both of them have, and I really look forward to these two presentations.
Hello, my name is Dr. Anthony Lembo, and I'm professor of medicine at Harvard Medical School, and I practice at the Beth Israel Deaconess Medical Center in Boston, Massachusetts. And today, as part of the Nancy and Bill Norton Patient Education Series, I'm going to be presenting to you a talk on complementary and alternative therapy for irritable bowel syndrome. Complementary and alternative therapy, otherwise known as CAM, is used as very common in the United States. In fact, approximately 35% of the adult population in the USA has used some form of CAM therapy within the past year. Interestingly, most, around 50%, do not tell their doctors that they're using these therapies for a variety of reasons. One of them seems to be that they think that doctors may not understand or agree with their use of these medications, which is quite interesting because we are very interested in these therapies, and we're going to be talking a little bit more about them as time goes on. Its use is more common among younger people than older, women more so than men, those with higher education, those with more severe symptoms, and those with poor satisfaction with standard therapy for their IBS. Now, CAM is based on a holistic approach. It looks at in the idea of CAM medicine, it looks at diseases that result from disturbances based on physical, psychological, and sociological and spiritual levels. The CAM modalities that we'll talk about in upcoming slides are all attempt to restore the balance and facilitate the body's own healing. There are two main categories of CAM, those of natural products, and these are most typically dietary supplements such as herbs, vitamins, minerals, and probiotics, and I'll touch on each of these in the upcoming slides. And there's another form of CAM medicine, which is known as mind-body therapy. And these include yoga, acupuncture, and Tai Chi, among many others that are available. This slide lists even more of the ones that are available. We won't be talking about all of these, but I just wanted to touch base on them. So you can see the number of natural products these are probably the most common that are used for IBS, as well as the number of mind-body treatments that are being used for IBS. In general, the evidence is relatively poor for CAM therapy. Most studies lack well-controlled, large multi-center trials for their data. So I'm just going to say that now because I won't have to repeat it after each of the following slides that we'll be talking about. So just remember that in general, these are not large, well-conducted trials like we would see in the FDA-approved medications. So let's first talk about prebiotics and probiotics for IBS. So prebiotics are high-fiber foods that act as food for the microflora with the intention to maintain balance of these microorganisms. So in other words, these are foods that we do not absorb, yet they go into your colon where there's multiple bacteria, and the bacteria will digest these foods. The most common are the fructooligosaccharides. These are found in garlic, onion, asparagus, among most of the vegetables and fruits that we eat. And studies have shown with fructooligosaccharides that there is slight improvement over placebo, but the NS means that the studies have not shown statistical significance. So just an FYI, there are other studies, but they're really with other types of oligosaccharides, but not yet showing strong data for them. Probiotics are live microorganisms that promote health benefits. The effects are strain specific. So what that means is that there are specific strains of probiotics that are being studied. And it doesn't mean that all of the probiotics in the same class would have the similar effects. There really should be strain specific. The guidelines that were recently published in the GI associations, the American College of Gastroenterology, the ACG, and the American Association, the American GI Association, the AGA, both recommend against the use of probiotics for the treatment of IBS due to the lack of significant studies showing significant difference in the fact that there are some differences that are found, but really not consistent data as of yet. There are some that I've listed here, including lactobacillus and some bifidobacters that have shown some improvement in IBS. But again, these are not large multi-center trials, but these are probably among the best studies that have been done in IBS. But again, they're not up to the rigor that's considered acceptable for at least for the ACG and the AGA for treatment of IBS. That doesn't mean we don't use them in our clinical practice. Some patients feel very strongly about them, and they have a strong rationale for why they may be helpful. And I don't think there's a lot of harm associated with them. But you remember that there's not a lot of data associated with it. I get a lot of questions on cannabis from patients these days, particularly with regards to its effects on IBS symptoms. We know that THC, which is the active component in marijuana or cannabis, it has an analgesic effect. But unfortunately, there haven't been a lot of studies in IBS specifically. There's one study with 10 IBS patients that found no difference in the threshold for a rectal distension protocol, so the extending a balloon within the rectum using a synthetic THC called dronabinol. But as it's suggested, that it may not have significant analgesic effects, at least at the doses that were given in this relatively small study. And another small study with 36 IBS with diarrhea patients. These patients were randomized to dronabinol, which is again the THC, a synthetic THC, 2 different doses. And patients underwent a scintigraphy, and that's a method to measure the transit within the GI tract, and also genotyping for some polymorphisms that are involved in the metabolism and in the activity of THC. They found no changes in the transit, but patients that did have one of the polymorphisms did show some delay in transit. So again, not a lot of data. And I wish I had more data for patients to recommend for or against the use of cannabis, but really there's very little information for it. And I think you have to be careful about the long-term side effects, which we don't necessarily have a good understanding of quite yet. Aloe Vera is an old treatment. We know that topically aloe-based gels can improve acne. They may help reduce pain as well. And some people with a variety of skin issues, such as herpes, lichen planus, and psoriasis have shown some improvement. You should know that before 2002, aloe was found in a number of different laxatives, but it was removed from the over-the-counter or the OTC market due to lack of safety data, not of known side effects or complications, but lack of safety data. There's relatively few trials. I was able to find 3 trials in IBS for a total of 236 patients. One trial showed some benefit, and 2 trials showed no benefit over placebo with the use of aloe. So really not enough data as of yet. And I showed one of the studies shown on the right here, showing some of the differences that may be seen with aloe in this small 4-week trial with it. Some of you may be familiar with iberogast. A number of patients do come into the office with this. This is a combination of a number of different products, as you can see from the list up above, including caraway, licorice, lemon balms, etc. And it's been used commonly for a number of different GI disorders, including dyspepsia, which is probably the most common use that we see. You should know that there have been some cases of severe liver toxicity that have been reported with iberogast. We should really do need to be careful about its use with it. There was a trial, a fairly large trial in IBS patients that were randomized to two different forms of iberogast, the standard one and then a more unique one, individualized one. And the control was bitter candy tuft as well as placebo as two different types of controls. So really a well-conducted trial. And as you can see from the study, if you just look at the IBSS score, which is a severity score for IBS shown on the left-hand side, at day 28, you do start to see some differences with iberogast compared to the placebo and the bittersweet candy tuft. And you can see that at day 28. On the right, you can see some effect on abdominal pain as well. So there is some data to support its use, but again, remember that it has been associated with liver toxicity. Berberine comes from a traditional Chinese medicine. It's been used for years to treat diarrhea in China. Its mechanism of action is to enhance the sodium absorption, which also in turn causes an increase in water absorption from the intestines, and may also have some anti-nociceptive effects through nitric oxide mediated pathways. So in a study done in China with IBS with diarrhea patients, you can see here compared to placebo, the study had about 130 patients with it, and you can see that there were statistically significant differences for Berberine after 8 weeks compared to baseline, as well as compared to placebo. So interesting data with this, but there's just not, again, there's not a lot of other studies. Turmeric sometimes comes up in our practice. It's been known to increase GI motility by activating hydrogen-producing bacteria within the colon. And also, this formulation that was studied called IQP-101, xanthophen, is a proprietary mixture of anti-inflammatory curcumins, fish oil, as well as peppermint oil. This is probably the best study, and you can see the changes with abdominal pain that were statistically significant beginning at week 3. So again, some data, and there's also the IBSSS score shown in the table above showing improvement with abdominal pain, but again, a relatively small study with it. This is an interesting study with glutamine, and excuse me, glutamine is an essential amino acid, but importantly, it's a major energy source for the epithelial cells that line the GI tract. And it's been shown, in the past that particularly patients like in an intensive care unit that may be deficient in glutamine, that they have an increase in permeability within their intestines. And that can be improved by giving these patients oral glutamine. And we also know that patients with IBS with diarrhea, some patients may also have an increase in permeability. So in this study that was done by Nick Byrne's group, they took a group of post-infectious IBS with diarrhea patients that had documented evidence of increased permeability. And they were given either 5 grams 3 times a day of glutamine or placebo for 8 weeks. And as you can see from the table, this is the change in their IBSSS score, which is a severity score for IBS, that there was a marked difference with glutamine and a relatively small difference with placebo. And it also seemed to improve frequency and consistency. And most importantly, I think, improved permeability associated with as well. So this is promising data. Again, a very select group of people, that those with IBS-D that have increased permeability, which represents probably less than 50% of those patients with it. Now, moving on to the mind-body type treatments, acupuncture is a common treatment. It's not only used in China, it's used throughout the world. Particularly in the United States, there are more acupuncturists per capita in United States than there are in China, for example. So these are commonly used, and it's based on a long-standing tradition of traditional acupuncture points on these main channels, or otherwise called as meridians, with it. And each point has a defined therapeutic action, and typically they'll use somewhere between 5 and 15 needles in a session, and they may also combine it with heat, electricity, etc. may be used as well. With regard to IBS, it's been well studied. There are a number of randomized control trials and several systematic and meta-analyses of these studies as well. And in general, they show that there's no benefit in IBS or quality of life compared to sham acupuncture. So just to keep that in mind. What's important to note, though, is that there is improvement with acupuncture compared in sham acupuncture compared to no treatment no treatment. And this was a study that we did a few years ago, and we had an acupuncture group, a sham acupuncture group, and a waitlist group. So as you can see, by looking at any of these graphs, let's just focus on the upper left. This is the global measure of improvement in IBS, that there was no difference between acupuncture and sham acupuncture, which is what showed in many other studies. There's a numeric difference, and we and others have calculated that you would need to power to do the, to really show a statistical difference, you need to have a very large trial, not an enormous trial, something along the lines we've seen in many drug trials, but usually somewhere between 500 and 700 patients would need to be done to show that to power this properly to see if there was a real difference. What was most striking was the difference between the sham and the acupuncture in the waitlist group. So doing nothing or no new treatments, doing sham acupuncture or acupuncture is better than doing no other treatment. Yoga has also been studied. It's commonly used by many people, not necessarily just for IBS, but within the group of IBS patients, there are a number of studies comparing yoga versus no treatment, and about a third of patients that are in yoga report clinically significant improvement in symptoms of IBS. They also report other improvements such as decrease in anxiety, decrease in the number of medications used. There are several studies looking at yoga versus exercise, such as in this case was a walking program showing there was no difference between these two groups. We know that they're both walking has also been shown to help IBS symptoms, or any moderate to rigorous exercise has been shown to help as well. Yoga versus medications. There's one study looking at yoga versus loperamide, which is an antidiarrheal medication used for IBS of diarrhea, showing again no difference between the groups. And we know that loperamide can improve stool frequency and consistency, but may not help abdominal pain. And a study looking at yoga versus psyllium plus diazepam, which is a benzodiazepine plus an antispasmodic, and again, now showing no differences between the medication group and the patients receiving yoga. So again, if yoga may be as good as some of these medications, if you want to look at it like that. Very interesting, yoga is also compared to a low FODMAP diet, and that's a very commonly used therapy, which you'll hear about in a separate talk, and showing no differences between the yoga and the low FODMAP diet in this case. So just to summarize, CAM therapy is commonly used, particularly in the United States, but also throughout the world. Most CAM therapies in IBS lack well-controlled, large, multi-center trials. And as I indicated, some of them are also associated with side effects, as I mentioned with iberic acid, although not very common. You need to be aware of the potential for that, particularly in the herbs, these medications, the potential side effects. Current data suggests that there may be some benefit for IBS for many CAM therapies, though given given the lack of well-conducted studies, further trials are needed to determine the appropriate patients and the potential for risks. Thank you much.
Hi, my name is Emily Haller, and I am a GI dietitian at Michigan Medicine with the Division of Gastroenterology and Hepatology. I'm very excited to be here with you today to talk about dietary interventions for a variety of GI disorders. So today in my talk, I'm going to highlight a variety of diet interventions or therapies for these GI disorders, including celiac disease, eosinophilic esophagitis or EOE, functional dyspepsia, gastroesophageal reflux disease or GERD, gastroparesis, inflammatory bowel disease, irritable bowel syndrome, and short bowel syndrome. So starting off with a gluten-free diet for celiac disease. A gluten-free diet is the only treatment for those with celiac disease. Gluten is a protein and it's found in certain grains. It's in wheat and rye and barley, and these must be avoided. Gluten-free oats must also be used. Oats that are not labeled gluten-free are not considered safe for those with celiac disease. Label reading is really important on the gluten-free diet. Gluten can be in some less obvious sources like regular soy sauce, certain seasoning packets, and even some broths, for example. Dining out can be difficult, but it's not impossible. Knowing what to look for and the certain questions to ask, ways to prevent cross contact are very important. There is a really helpful article by the Celiac Disease Foundation, which can be found here, about dining out and social eating. They have the dining dozen, which is 12 different questions you might want to ask depending on what's being ordered. And again, tips to talk about or think about to reduce cross contact when eating in social situations and dining out. A gluten-free multivitamin may be necessary for those who are not able to meet their nutrient needs with diet alone. And because of the nuances of a gluten-free diet, it is highly recommended to work with a knowledgeable GI dietitian, especially when someone is first diagnosed. It can really help set you up for success. Many individuals with irritable bowel syndrome will associate their symptoms with eating or eating particular foods and restrict their diet to improve gut symptoms. Research has shown that a diet that is low in fermentable, oligosaccharides, disaccharides, monosaccharides, and polyols, or FODMAPs for short, can improve gut symptoms for those with IBS. FODMAPs are short-chain carbohydrates. So they're short-chain sugars or short-chain fibers, and they're found in a wide variety of different foods. The low FODMAP diet is not a forever diet. It is actually done in 3 phases, which you can see here. So the first phase is the elimination phase, where we have someone remove or avoid high FODMAP foods for a short period of time to see if they feel better. If someone feels better, then we have them move forward to the reintroduction phase, which involves adding back in high FODMAP foods in a strategic way to identify triggers, and just as importantly, to identify what sits well. And those are the different FODMAP groups to your right. So the fructans, the GOS group, lactose, fructose, and polyols. And then the third phase is the personalization phase. And this phase is kind of ongoing, long-term maintenance or management of gut symptoms. And what that looks like is going to be a little bit different for everybody, but it involves bringing back in the high FODMAP foods that are not triggers and limiting or avoiding the FODMAPs that do trigger gut symptoms, with the goal being increasing the diet to have the most variety while maintaining symptoms long-term. We may use specific digestive enzymes here or some other tips and tricks based on a person's triggers. It is also important to note that not everybody with IBS is going to feel better on a low FODMAP diet. If someone doesn't feel better in that elimination phase, then we have them come off of the FODMAP diet and add back in those high FODMAP foods. There is no benefit to avoiding FODMAPs unless it helps improve gut symptoms. And then in the case that it doesn't work, we want to go back to the healthcare provider, right? And ask, what are some other options, other modalities, even other nutrition strategies that may help improve gut symptoms? So diet interventions for short bowel syndrome. There's really not one best SBS diet. And what I mean by that is it's going to look a little bit different based on the person's anatomy, how much length they have left in their digestive tract, and how well that is functioning. Some people with short bowel syndrome are going to receive their nutrition partially or fully, or maybe IV fluids through a vein, so total parenteral nutrition. Some general diet tips: if someone has some of their colon remaining, a high complex carbohydrate diet is recommended, versus if someone has a jejunostomy or a high output ileostomy, a higher fat diet may be beneficial and recommended. Chewing foods well to help break them down can be very helpful. Avoiding concentrated sweets and beverages. This one is huge. So think about our juices, sodas, desserts, sweet coffee drinks, some sports drinks. High sugar loads can act as a laxative. They can pull more water into the gut, and that can speed things up and create more diarrhea or higher ostomy output. Eating small, frequent meals spread throughout the day, limiting beverages with meals. So just, starting early with hydration, sipping on fluids throughout the day, and keeping drinks to about 4 ounces or half of a cup at a meal is a strategy to try. And then salting foods liberally can be helpful. An elimination diet can be used for those with EOE in place of medications to manage their disease. So what this can look like is at least 6 weeks of an elimination diet, followed by a scope, so an EGD that looks at the esophagus and takes biopsies to assess response. And the diet protocols that we can use are a 2-food elimination diet that takes out the top 2, main triggers or allergens for EOE, and that's dairy and wheat. The 4-food elimination diet, which adds on no egg or no soy. And then there's the 6-food elimination diet, which is the most restrictive because that is taking out, dairy, wheat, egg, soy, and peanuts and tree nuts, and fish and shellfish. So pending that somebody responds to this, their eosinophils, significantly decrease with an elimination diet, then we have them add back in each food one at a time, followed by a scope to assess, what their trigger or triggers are. Unfortunately, we cannot go by symptoms. We have to do scopes to see what's going on in the esophagus to identify triggers for people with EOE. Label reading is also really important here. I wanted to show you some examples of some less obvious sources of the top 8 allergens. We chatted a little bit about wheat earlier when we were talking about gluten for those with celiac disease. Soy is, of course, in soy sauce, marinades, teriyaki sauce. It can be in different gluten-free products, crackers, breads, baking mixes, some vegan products, dairy-free margarines, and granola bars. Milk can be found in deli meats at times, gluten-free baked goods, protein powders, and granola bars. Nuts also can be found in granola bars, pesto, different, of course, nut flours like almond flour. And then fish can be found in Asian cuisine, usually through the use of fish sauce. So we've chatted about some very specific nutrition therapies for GI conditions. And then now I want to talk a little bit about strategies, who may benefit from these, because it can be more than one condition, and then what to try. So starting with smaller portion sizes and a lower fat diet, who may benefit from this eating strategy? People who have GERD, people with functional dyspepsia, and those with gastroparesis. So some things to try that may offer symptom relief is eating regular meals and snacks spread throughout the day. paying attention to portion size, right? Not under eating during the day or skipping meals and having one main meal. Looking at the consistency of foods, focusing on soft, tender foods, foods that have more moisture, liquids versus those like tough and roughage foods. So think like kale, raw kale salads, large amounts of nuts, popcorn, meat with a lot of like fat or gristle. Those would be some examples of like tough and rough foods that might worsen gut symptoms. And then spreading fat throughout the day can be helpful. That sometimes happens naturally when we switch to eating, maybe smaller meals spread throughout the day, avoiding the use of a lot of oils, a lot of butter, avoiding greasy meals and fried foods would also be a strategy to implement here. So a high fiber diet, who may benefit from this? People with inflammatory bowel disease that are in remission, people with diverticulosis, and potentially people who have constipation. So what to try? You want to eat more plant foods. Plant foods give us fiber. So fiber is found in your fruits and vegetables, whole grains, nuts and seeds, and legumes. So beans and lentils. What I recommend here is if and when we're eating a lower fiber diet, we want to gradually increase fiber intake. It's not something we want to do in one day because that can lead to a lot of symptoms. It can lead to more gas, bloating, distension, maybe cramping or pain. And that can be discouraging. That can make us feel like, hey, I can't eat these foods, they're hurting me. When really we have a much better chance of tolerating a higher fiber diet when fiber is increased gradually. With that, we also want to make sure we're drinking plenty of fluids and staying hydrated. So how can we do this? You can try adding some fruit and some nuts or seeds to a morning cereal or yogurt and do that for a couple of days. Let your body adjust. Then layer in another fiber-containing food to another meal. Maybe at lunch, you'll try a whole grain like quinoa or brown rice. You could do oats or trial a bean or lentil pasta instead of a white pasta. You could open a can of chickpeas or white beans and add those to a soup or salad, and then maybe adding some extra vegetables at your dinner meal. And those can be fresh or frozen or canned. All of those are going to provide your body with fiber. On the flip side, we may need to use a lower fiber diet. So who may benefit from this? People with diverticulitis, so active inflammation of the diverticula, people who have gastroparesis, those with inflammatory bowel disease who are in a flare, who are struggling with fiber-containing foods, or people who present with intestinal strictures, maybe have a history of small bowel obstructions. So some tips here to still be able to eat some fiber-containing foods, but in an easy to digest way include peeling thick skins of fruits and vegetables, blending or pureeing, so food processor, a blender, juice fiber-containing foods, cooking produce until tender. While this doesn't remove the fiber, it makes it a lot easier to digest. So think about something that's like fork tender. You can pierce a fork through it or mash it with a fork. Chewing your foods really well can help because it will break down that particle size of the fiber. And then you can grate or chop fruits and vegetables and mix them into other dishes as well. Because we do still want to try to get fiber in the diet. Low fiber doesn't mean fiber free. So we want to try to find ways, get creative to be able to get these nutrient dense foods into your diet. So there have been some common themes or common goals among these dietary interventions. And one is optimizing diet quality through increasing the variety of foods, nutrient dense foods, foods that people enjoy, minimizing and improving gut symptoms, and then supporting a person's overall health. And that includes their relationship with food. So if you are struggling with what or how to eat, you find yourself eating a really limited diet and are not able to successfully expand what you're eating, then I highly recommend partnering with a GI dietitian. GI dietitians are food and nutrition experts who can help you navigate how to eat with a GI disorder. A good place to start is by asking your doctor for a referral. If there is a GI dietitian, present in the clinic that you can meet with, or if your provider has somebody that they can refer out to in the community, maybe a private practice dietitian who specializes in, GI disorders, GI health. You can also find a dietitian online. So IFFGD has a search. The AGA is working on coming out with a vetted GI dietitian list as well. GI On Demand, which is a virtual platform, this is a partnership between ACG and GastroGirl, also has vetted GI dietitians that can meet with people online through virtual appointments. And then they also have online patient education resources, so webinars and modules that people can use. And that brings me to the end of my talk. Thank you so much today for your attention. I hope you found this helpful.
There's our kitchen right there.
Hello, and welcome back to the second day of the Norton Educational Series 30th anniversary event. My name is Cecile Rooker. I'm the president and executive director for IFFGD. With me today are Drs. Bill Che and Dr. Lynn Chang, who are experts in this field of GI disorders, who are helping to co-host this event from sunny South Carolina. Wasn't so sunny yesterday, but today it is. And so we're really thrilled to have them with us today. So we had these great topics, right? So we're getting past sort of the traditional therapies that people think about, over-the-counter medications, prescriptions. I mean, really getting into what people are very interested in, which is the dietary, behavioral therapies, and also complementary and alternative medicine. As Bill mentioned before, Tony Lembo is one of the experts in this space. One thing he mentioned in his talk that I found very interesting is that so many patients don't tell their physicians that they're trying some of these other non-traditional therapies or herbs and things like that. And do you find that to be true in your practice as well?
Oh yeah. I mean, I'm sure Lynn will have a strong opinion about this being from California, but even in Michigan, there are many patients that are utilizing CAM therapies. In fact, I think it was the IFFGD survey from 10 years ago that suggested that upwards of 40% of patients with disorders like IBS are using some form of CAM therapy. Yeah. So it's incredibly common. I think the big issue is that there's a hesitancy on the part of both patients and providers to communicate on this issue. So providers oftentimes don't ask and patients oftentimes don't tell. And I think it stems from issues of credibility around the veracity of the data for those therapies in patients with functional disorders.
Right. Yeah, I mean, it's not even part of when you do the intake of the medical history, you have medications, surgeries, past medical history, but you don't have anywhere about the complementary alternative medicine. So it's not asked by the staff or the physician, a healthcare provider, and the patient doesn't necessarily provide that information voluntarily, provided unless you ask. If you ask about it, then they do.
Should they be talking about these things?
If they're using it for the treatment of the symptoms they're coming to see you about, I would think so.
I think so. And by the way, as you know, Tony pointed out, some CAM therapies are evidence-based at this point for patients with a variety of gastrointestinal symptoms, whether you're talking about nausea or constipation or IBS. There are CAM therapies that look quite promising as treatment alternatives for those patients.
Definitely think patients who have a lot of coexistent conditions, and a lot of them may have a shared pathophysiology cause. You know, when people have fibromyalgia, they have a lot of muscle pain, and they have IBS or constipation or chronic abdominal pain, migraines. They, I think, search for CAM therapies because they really address the whole body and not just one organ system. Or when they have severe symptoms, they'll use it either to add to whatever treatment they're getting, or they'll even use it on its own. But it's really where we need the integration of Western and Eastern approaches, and not to say you can only do one or the other, but to really be open to utilizing both would be helpful.
I not uncommonly refer patients for acupuncture, for example, patients with constipation or pain.
What other GI disorders would you consider referring a patient out for some sort of complementary and alternative therapy?
Nausea. Chronic nausea is a great candidate condition. And, I think Chinese herbal therapy is another potentially attractive treatment option for some patients. Now, The reality is that all of these things, I don't think necessarily do any better than the things we have to offer in Western medicine, meaning that it's subgroups of patients with constipation, nausea, IBS that get better with any of these herbal therapies, acupuncture, et cetera. But it's nice to have those additional arrows in your quiver, because the reality is none of the treatments that we have are a silver bullet for every patient with these symptom-based conditions. So having lots of arrows in your quiver increases the likelihood that you're going to find something that's effective by either in isolation or in combination for the patient sitting in front of you.
See, the other issue I think is that, like, we're guided a lot by guidelines, which means that you're looking at, well, we talked earlier about randomized controlled trials and the evidence, but the same with probiotics. A lot of the quality and the way the study design has been conducted, it doesn't meet what the guideline committee would say is high quality to recommend it. And CAM therapy is the same way. They're not conducted in the same rigorous fashion as medications that the FDA reviews. So the guideline may say there's not enough evidence. It's not, but it could be. It's just that we haven't met that threshold by which you can really grade the evidence. But it could be efficacious in particular individuals. But like Bill said, which I think is a really important point, is that for any of these conditions, not one treatment is not going to help every patient.
That's right.
Sure.
You really have to tailor to not only what the data shows or what you think will help the patient, what the patient is interested in.
Absolutely.
If they're not interested in it, then it's probably not worth pushing or discussing it more if you really think it's something they should use.
Absolutely. So please, I think the take home message is to talk to your healthcare provider about what CAM therapies might be good for you, and then also what you might be already looking into and participating in. So please, always have those open and honest conversations with your healthcare provider. So let's talk about Emily Holler's presentation on diet. She's so fantastic, and she covered so much. Like, she covered so many different areas that a dietitian is helpful. And so one of the questions that we had is talking about a diet for constipation specifically. So that's one that she really didn't mention that much. So is there some, foods that can help with the aid in constipation? I know that people have often said fiber, but then patients say that a lot of times with constipation, that's not very helpful. So do you have any things that you suggest to your patients in clinic?
Yeah, it's a really exciting area because we're starting to see evidence. We published a paper this past year on the use of kiwi fruit for chronic constipation, and we specifically compared 2 peeled kiwi fruit to 12 prunes per day, which is a lot of prunes, but it's a lot of prunes. But prunes work really well for constipation, interestingly, probably as well as many of the medical therapies that we use, but you have to take a lot. Like, taking a couple prunes a day is not gonna help much with your constipation. The interesting thing is that prunes, in our study, prunes were the most effective, more effective than kiwi, but kiwi was much better tolerated. So it didn't cause as much gas and bloating, because remember, the prunes are not low FODMAP, but kiwi is. So in terms of causing issues like abdominal cramping, gas, or bloating, kiwi essentially doesn't do that.
Fantastic. Yeah, so I actually saw the earlier data published in Europe on the kiwi. And so it's really exciting that you were able to do that and learn a little bit more. So there are some things that people can do with their constipation, and so that's great. And I believe in our later this year, we'll be publishing a special edition of our Digestive Health Matters magazine. And in there, Emily Holler has a recipe for a smoothie for constipation that helps with constipation. So be looking for that, and make sure that you're signed up for the IFFGD newsletter so that you can make sure to get a copy of that magazine when it is available. So a lot of people want to use the registered dietitians, and they have some concerns about insurance and insurance not covering the dietitians. Are there websites or apps that might be beneficial if they are unable to see a dietitian? And before you answer that question, I want to let you know at home that we do realize that this is an issue here at IFFGD, and we would be more than willing to send a letter with you to your insurance company letting them know the importance of diet and GI health. Here at IFFGD, we have several of those nutritional letters that have been co-written by some dietitians, where we can try to convince your insurance company to help with that. No guarantees that it will work, but we're happy to do that. Please contact us if you would like some assistance with dietary therapy or any other therapy that your insurance is not covering. But let's say that that doesn't work and you aren't able to go see a registered dietitian, which would be the gold standard because they can really tailor the approach. Are there other ways that people can get this without just going out on Google, where there's a lot of information that's not correct? And a lot of people selling supplements and teas that are not helpful. So are there any suggestions? What do you suggest with your
Yeah, there's a ton of information out there, and like very much like we were talking about the digital therapeutic space, which is rapidly expanding. Also, the number of websites providing information about diet therapies for GI conditions is also rapidly expanding. Monash University really has the gold standard in terms of mobile applications called the Monash University Low FODMAP app, and it provides information about the FODMAP content in various foods. It also provides some recipes. There's a website that we put out called www.mygInutrition.com, which provides videos that explain how FODMAPs cause problems and the 3 phases to the low FODMAP program. There's some excellent websites put out by private dietitians. Kate Scarlatta and Patsy Katsos have really boundless information on their websites that I've looked at, and it's excellent. And then finally, for those that aren't computer savvy or don't want to go to the digital realm, there are a lot of books actually now, multiple books by Kate and Patsy, Rachel Pauls, as well as others that go into a lot of detail in terms of how to implement the low FODMAP diet specifically into their day-to-day regimen.
Fantastic. And so for those of you at home, if you would like more information, I know Bill Che went through that really quickly. Just contact us at IFFG and we're happy to share those resources with you again.